How many patients do we see with myelodysplastic syndrome, otherwise known as MDS? Probably not many on a daily basis, but we need to be familiar with the proper protocol for conducting a thorough workup when we suspect MDS. Understanding the intricacies of this diagnostic process is crucial, so let's delve into the essential components. I'm Dr. Sanjay Juneja, and this is the first of a 5-part CE-certified TikToktivity on MDS and anemia from the Medical Learning Institute. Yes, you heard that right. CE-certified, folks. That means peer-reviewed, evidence-based educational material to help guide treatment for your patients. First, start by taking a good history and physical exam. You want to know about smoking, occupational, chemical exposures, prior chemotherapy and radiation, all of which are risk factors for MDS. Next, you want to accurately assess the patient by evaluating for alternative causes for cytopenias, such as nutritional deficiencies, hypothyroidism, and of course, autoimmune disease. If this workup is non-revealing, you then proceed with a bone marrow biopsy, which is the gold standard for diagnosing MDS. Patients must have dysplasia in at least 10% cells in a given lineage, blast cell count less than 20%, and plus minus certain cytogenetic abnormalities to meet MDS diagnostic criteria. In the past, the only treatment options available for patients diagnosed with low-risk disease and anemia were blood transfusions, lenalidomide for isolated del(5q), and ESAs. We now have Luspatercept. We'll get into ESAs and other therapeutic options, such as Luspatercept in video 4, but I did want to mention that while ESAs have been the gold standard of treatment for patients with anemia in low-risk MDS, and while they're typically well tolerated with patients responding to them early, there are those who eventually become refractory, and then we need something else. ESAs can also be a burden as patients have to come into clinic at least once a week versus every 3 weeks with Luspatercept. Again, more on this in a later video. Luspatercept is an erythroid maturation agent that works by binding to select TGF-beta superfamily ligands, thereby modulating and transforming growth factor beta signaling pathways by enhancing late-stage erythropoiesis. I wanted to set you up with the knowledge about clinical trials like the Medalist and PACE trial that led to the FDA approval of an alternative to ESAs with Luspatercept for patients with anemia in low-risk MDS, as well as a more recent trial, COMMANDS, which showed similar findings: red blood cell transfusion independence and increased hemoglobin levels, which is game-changing. Yeah! On top of that, Luspatercept is generally well tolerated with manageable side effects and a generally consistent safety profile across studies of Luspatercept. But check them out in the link below. Remember, this is all evidence-based. This is a huge advancement in our treatment armamentarium for anemia in low-risk MDS, so make sure you know about it for your patients. To get credit for this activity, don't forget to answer the questions on the link below.
Do you know about the genetic abnormalities and the presence of ring sideroblasts as they impact treatment decisions for low-risk MDS? I'm Dr. Joel Alcid, and this is a second of a 5-part CE-certified TikToktivity on anemia in low-risk MDS from MLI. If you missed the first video by Dr. Sanjay Juneja, also known as the OncDoc, please check that out at your earliest convenience. Certain morphological criteria must be met to diagnose MDS. Of note, there are patients with anemia due to idiopathic cytopenia of unknown significance, or ICUS, or clonal cytopenia of unknown significance, or CCUS, whom we do not want to confuse with having MDS. These patients may develop disease but do not meet the criteria. We should always be cognizant of the impact a delayed diagnosis or a misdiagnosis can have on patients' quality of life. MDS can be classified using the updated WHO 2022 or the ICC 2022 criteria, which differ in a few ways. For the WHO 2022, MDS is classified by defined genetic abnormalities, such as an isolated deletion of 5q, SF3B1 mutation, or biallelic TP53 inactivation. MDS is also morphologically defined by blast count, fibrosis, and hypoplasia. Unlike the WHO, the ICC categorizes MDS based off single lineage versus multi-lineage dysplasia. It also introduced a new MDS/AML category defined as having 10 to 19% blasts in the peripheral blood or bone marrow. See the notes below for more information. Once the initial diagnosis of MDS is made, patients are risk stratified using the IPSS-R to determine prognosis and choice of therapy. The scoring system considers cytogenetics, the degree of cytopenias, and bone marrow blast percentage. A score of less than or equal to 3.5 points is considered low-risk MDS, which includes patients with very low and intermediate risk disease. Median survival is approximately 3 to 9 years. Check out one of these handy IPSS-R online calculator tools. A new scoring system, IPSS-M, incorporates molecular abnormalities detected by next-generation sequencing to further help define the MDS prognosis. For example, the SF3B1 mutation occurs frequently with ring sideroblasts, is associated with an indolent disease course and a more favorable outcome. In contrast, the P53 mutation is an adverse prognostic risk factor. I must specify the P53 allelic state matters. Patients with 2 versus just 1 P53 mutations have poorer outcomes. Lastly, patient-specific risk factors such as age, performance status, comorbidities should be considered when determining prognosis and treatment. Please click the link in the comments to find out more about this topic as well as other videos in this series. Now, I'm going to pass things over to the OncBros, who I've tagged below. Let's keep this conversation going. To get credit for this activity, please don't forget to answer the questions on the link below.
Do you think you're using the best strategies to ensure optimal care coordination for patients with anemia and low-risk myelodysplastic syndrome? Let's find out. We are the Oncology Brothers. Let us talk about how we can collaborate and use all our available resources to enhance health outcomes for individuals with symptomatic anemia and low-risk MDS.
As an interdisciplinary care team in hematology oncology, we rely a lot on people in our team. For example, our nursing staff, who can play a pivotal role in appreciating some of the chronic side effects in our patients. As a hematologist, it is important for us to remember that we have resources at our disposal, and relying on other team members is critical. More on this in later part 5 video with Dr. Andrea Dean.
Better outcomes for our patients due to a cohesive interdisciplinary team are backed by multiple studies. The secret sauce to optimize our patient outcomes still remains trust, empathy, and exploring how we can do better. Then focusing on how symptomatic anemia impacts the quality of life or how our available treatments will improve their day-to-day activity is so important. One point that I cannot stress enough is the need of us as a hematologist in the community to reach out to our primary care physician peers to make sure of the importance of timely referral. This space is rapidly evolving, and we want to make sure that we can manage some of these symptoms in a timely manner.
Now, once we collaborate, coordinate, and ensure accessible care for our patient at right time based on their needs, values, and preferences, we can prioritize therapies that reduce transfusion dependence for our patients with anemia in low-risk MDS, especially those who have become refractory to erythropoietin-stimulating agents. The impact that these decisions have on quality of life and long-term outcomes is extremely important. We have assessment tools we can use to ask questions about their symptoms, in particular fatigue, weakness, and about their physical, emotional, and social health. It can be challenging to incorporate patient-reported outcomes into our practice, as these can take time. In fact, one study on the impact of MDS and quality of life found that patients care more about how symptoms impact their everyday life.
Finally, fostering a collaboration between academic and community hematologists and oncologists to help manage patients with anemia in low-risk MDS is what we would like to emphasize. Hematology and oncology and patient care is a team sport. Thanks for joining us. Now head over to the part 4 of the video tagged below to hear more, and to get credit for this activity, don't forget to answer the questions on the link below.
Hi, Mikkael Sekeres here, Professor of Medicine and Chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center, University of Miami. Welcome to Part 4 of the CE-certified TikToktivity series on myelodysplastic syndromes from MLI. If you haven't already, please check out the other videos in this series. While a substantial number of patients with lower-risk MDS may have mild or asymptomatic anemia that requires watchful observation, some require treatment to manage the disease. So let's talk about them. In the first video of this series, Dr. Juneja spoke a bit about the burden that ESAs can have on a patient's quality of life. Let's talk a bit more about ESAs, given they've been the standard of care for patients with anemia in lower-risk MDS for decades. An ESA regimen should be started with a treatment goal of maintaining hemoglobin levels that are sufficient to avoid red cell transfusions and maintain quality of life, typically at hemoglobin levels at or above 8, since we often start initiating transfusions for hemoglobins of less than 8. In a meta-analysis we conducted looking at 20 years of published literature on ESA use in MDS, the hematologic improvement rate to ESAs was about 40%, and in another study, they lasted for about 12 to 18 months. The NCCN guidelines do support use of an ESA for the upfront treatment of patients with lower-risk MDS with low baseline EPO levels, especially if they haven't yet needed red blood cell transfusions. You can find all this information in the notes. What option do you have if your patient has the deletion 5q karyotypic abnormality? Well, lenalidomide, of course. Lenalidomide may be used as first or second-line therapy for patients with lower-risk MDS and deletion 5q and who are transfusion-dependent, or a second-line therapy after ESA failure. Results from the Phase 3 MDS 003 trial that examined lenalidomide versus placebo showed that more patients who received 10 milligrams and even 5 milligrams once daily achieved red blood cell transfusion independence, which was the primary study endpoint, lasting 8 weeks or longer versus placebo. A study we conducted showed that if you start high with a 10 milligram dose for 1 to 2 cycles and then reduce that dose, patients stay on lenalidomide for longer and may even live longer. What can we offer patients who don't have the deletion 5q, lower risk MDS, or who don't respond well to ESAs? This is where Luspatercept comes in. In the first study conducted in patients with lower risk MDS who had ring sideroblasts and were already exposed to ESAs or unlikely to respond to them, results from the Medalist Phase 3 trial showed that 38% of patients who received Luspatercept met the primary endpoint of transfusion independence for 8 weeks or longer, compared to placebo, which was 13%. What if you want to use Luspatercept earlier in a patient's disease course? Well, Luspatercept was also studied here and compared to ESAs and almost doubled the response rate at 60% versus 30%. It's important to remember that most of these responses were seen in patients who had ring sideroblasts. Dosing decisions for all these drugs must be considered when patients experience adverse events such as neutropenia or thrombocytopenia, in which case dosing may need to be decreased or even interrupted. We just covered a lot of content, so thanks for listening, and check out the link to access full manuscripts of the trials discussed here. We'll ask Dr. Dean to take us over the finish line with the last video of this series. Just click the tag in my caption. And before you move on to get credit for this activity, don't forget to answer the questions on the link below. Thanks for watching.
I'm Dr. Andrea Dean, and this is the last of the 5-part CE-certified TikToktivity on anemia and low-risk MDS for MLI. Up next, how to develop long-term individualized care plans for patients. To begin, I would like to share a case. About 4 years ago, I had a patient with low-risk MDS and ring sideroblasts that was transfusion dependent. I initially started him on an erythropoietin agent. I then switched him over to azacitidine due to no response. After several weeks of therapy, he returned to clinic for a follow-up visit with me. I was excited for him. He was no longer needing blood transfusions, but despite this good news, I can sense that he was troubled. He shared with me that he was the sole caregiver for a family member at home, making it hard for him to keep up with his frequent chemotherapy appointments. He then asked if he could try this new medication called Luspatercept, which is given every 3 weeks. That day, I switched his treatment. He remained transfusion independent, and his appointments could be stretched out every 6 to 12 weeks, which made him happy. This case drives home the importance of why patients should be a part of the treatment decision-making process. Therapy should align with patients' preferences, goals, and values to ensure the best optimal care. Additionally, when creating treatment plans, you should consider health inequities, social determinants of health, and mental well-being. You should ask patients questions such as, do you have good social support? Do you have transportation to appointments? Do you have money for gas, parking, and food? Are you experiencing anxiety or depression due to your cancer diagnosis? Addressing any issues uncovered improve treatment adherence and allow you to build a care team consisting of a social worker, psychologist, or any other necessary professional. Patients diagnosed with anemia and low-risk MDS require long-term follow-up with hematology. You should assess for response to therapy, review medication side effects, and monitor for disease progression at each visit. Typically, patients have appointments every 1 to 6 months, depending on the severity of cytopenias and treatment regimen. Many patients remain on therapy as long as they're responding and experiencing little to no side effects. In addition to a hematologist, patients should continue to follow up with their primary care providers to receive treatment for any chronic medical conditions, age-appropriate cancer screening, and immunizations. Thanks for watching. If you've seen all 5 parts of this TikToktivity series, you can collect CE credit. If you haven't seen all 5 videos, I'm tagged in my live education page. Head over there to watch the rest of the series.